I'm Andrew Holden from Auckland, New Zealand, and I'm delighted to welcome you to the Charing Cross Shockwave Symposium on Intravascular Lithotripsy, really emerging from data to daily clinical practice. Now, joining me in this symposium are my colleagues, Dr. Konstantinos Stavroulakis from Munich in Germany, and Dr. Stefano Fazzini from the University of Rome in Italy. And both my colleagues have extensive experience with intravascular lithotripsy, and they're going to share that with you following my initial presentation. So I'm going to present some new data, primarily from the Shockwave observational registry, and these are my relevant disclosures. We know that intravascular lithotripsy has been with us for over 30 years, largely used in the management of renal calculus disease and shown to be safe and effective. But Shockwave miniaturized the intravascular lithotripsy system with miniaturized lithotripsy emitters mounted within an angioplasty balloon to achieve intravascular lithotripsy. So the catheter in the IVL procedures is dilated to provide balloon wall apposition in the calcified stenosis. The emitters produce gas bubbles within the fluid-filled balloon that generate acoustic pressure waves using lithotripsy to microfragment the calcium, both the intimal and medial layers of the calcium, and change the compliance of the vessel to allow safe expansion at low pressure. Currently, the generator delivers 1 pulse per second, and as mentioned, both superficial and deep layers of calcium are fractured or cracked. The experience of IVL has included both concentric and eccentric calcium. There's been, as we'll discuss, broad experience in lower limb arteries for peripheral arterial disease, but the coronary arteries have also been treated, and there are 3 catheters available: the M5 for femoropopliteal and iliac disease, the S4 for tibial disease, and of course the C2 for coronary disease. Let's then have a look at some relatively new data from the observational study looking at calcified long lesions. Now, as many of you are aware, there's an extensive portfolio of data for lower limb peripheral arterial intervention with Shockwave. The first in human DISRUPT PAD 1 and 2 trials combined 95 patients showing safety and efficacy in the femoropopliteal segment. A small DISRUPT BTK trial also showed safety and efficacy. And the much larger and very important DISRUPT PAD 3 randomized controlled trial has finished recruitment, and we've seen the first procedural outcomes of that trial. We are going to focus on the DISRUPT PAD 3 observational registry now, a 1,500 patient observational registry obtained from the US, from Europe, and from New Zealand. We do know that long calcified peripheral arterial lesions are challenging to treat. Angioplasty is associated with the high incidence of flow-limiting dissections and residual stenosis in these lesions. And while drug-coated balloons and drug-eluting stents may improve patency, their performance in heavily calcified arteries is certainly inferior. Atherectomy can also be treated in these lesions, but is associated with significant complications such as embolization. Now, we know intravascular lithotripsy has been safe and effective in treating calcified peripheral artery stenoses, but we're looking for more experience in longer lesions, that is greater than 15 centimeters in length. And we've managed to extract that data from the PAD3 observational registry, a real-world peri-procedural outcomes registry. We're looking at a subset of patients with lesions greater than 15 centimeters that were heavily calcified and received IVL plus or minus an adjunctive therapy between 2017 and 2020. 253 patients, 254 long lesions, and we'll look through the outcomes. We can see this was a very challenging patient group, a high incidence of hypertension, hyperlipidemia, and diabetes, but also a quarter of the patients had chronic renal insufficiency, and over 20% of the patients were on dialysis. While most of the patients were claudicants, there was a high incidence of critical limb ischemia. If we have a look at lesion characteristics, again, a challenging group. 62% chronic total occlusion, a very long lesion length with a mean of 217 millimeters, and the calcified lesion length being longer at 236 millimeters. We can see that there were predominantly lesions in the femoropopliteal segment, with a small number elsewhere, particularly below the knee. If we have a look at procedural characteristics, you can see these listed here. You can see that IVL was the only calcified calcium modifying therapy in the majority of cases. And also the majority of cases, the IVL was used as a vessel preparation device, followed by a drug-coated balloon or a drug-eluting stent. A small number of patients had an adjunctive calcium modifying therapy, be it a specialty balloon or atherectomy. Interestingly, when we look at the outcomes in terms of reduction of stenosis after IVL, you can see the outcomes were no different whether the patient had a stent or not. Here's a case of ours with diffuse calcified stenotic disease. You can see the angioplasty balloon, the IVL catheter, initially showing a stenosis, but after IVL at low pressure, this is fully effaced. An excellent result, and a drug-coated balloon which provided an excellent final result. Here we can see a much more challenging case again from our institution of a calcified chronic total occlusion. Actually, the wire went subintimal and a re-entry device was required. After IVL, we got some areas of residual stenosis, not surprisingly, but these were very easily managed and beautifully prepared for a superior stent with an excellent final result. If we have a look at the angiographic outcomes, you can see that there was a significant improvement in diameter of stenosis severity after IVL, and then a final stenosis of around 30% mean stenosis with a significant improvement in luminal diameter. A very pleasing complication profile with a low incidence of dissection. This was the common reason for needing a stent, and a very low incidence of perforation, no cases of distal embolization. If we have a look at some lesion characteristics and compare these to the randomized controlled trial and the overall observational registry, you can see that despite in the long lesion subset being over twice the lesion length, we can see also a much higher incidence of chronic total occlusion, as has been previously mentioned. But despite those much more challenging morphologies, you can see if we compare the outcomes in terms of diameter reduction, a very similar and pleasing reduction in stenosis severity after IVL and our final outcome after subsequent treatment. We can also see a very low incidence of complications, as has previously been mentioned. So in conclusion, this study represents the largest real-world cohort of IVL treatment for long lesions that are heavily calcified. We've seen excellent improvement in diameter stenosis and luminal gain with an excellent safety profile, no distal embolization. Adjunctive therapy was usually used at the operator's discretion, most commonly drug-coated balloons, occasionally stents. Future studies assessing long-term patency and revascularization are needed to understand the durability of IVL treatment in long calcified lesions. Thanks very much for your attention, and let's move on to my colleagues for further presentations.
Hello everybody, my name is Konstantinos Stavroulakis. I'm consultant on vascular and endovascular surgery in LMU University in Munich, and I'm happy to be with you today and present you our experience with the treatment of CLTI patients with the use of intravascular lithotripsy. when we treat severely calcified disease, we face many challenges. The crossing is very difficult. We have to achieve an optimal luminal gain, which is most of the times a major issue. We have to find definite treatment so that we will keep the vessel patent also in the long run, and of course to avoid adverse events. We should never forget that patients with calcified disease, patients especially with a chronic limb threatening ischemia and severely calcified lesions, are most of the times patients with chronic kidney disease, patients on hemodialysis or diabetics, where a complication during the procedure might be disastrous. And especially when we talk about above the knee disease, the femoral-popliteal segment, we have to keep in mind that the anatomical environment, the unique environment of the SFA and the popliteal artery raise additional challenges, and sometimes the use of scaffolds should be avoided. As we see in these images, even modern scaffolds can break with the development of pseudoaneurysms. We see many times occlusions of scaffolds, especially when we go up to the popliteal artery, because of the torsion and the mechanical and the complex mechanical environment of the popliteal artery and the SFA. So we do have many different vessel prep tools for the treatment of calcified disease. We have different kinds of atherectomy, specialty balloons, and so on. But the problem that we face with the current technologies is that they are very time consuming. They need prolonged procedures, many repeating angiograms, very different planes, and mainly they target the intimal calcium. And we should never forget that in the majority of these procedures, the risk for distal embolization is quite high. That's why the use of a distal protection device is suggested. We should also keep in mind that the real CLTI world is very different from the patients that are treated most of the times or are included most of the times in clinical trials. We talk about patients rather for class 5 and 6. We have previous interventions or surgery, patients with chronic kidney disease or end-stage renal disease, infections, and of course common deep femoral disease, and as I said before, patients with increased comorbidity and morbidity. That's why I want to share with you some cases about real-world CLTI patients where the use of IVL can be very helpful. It can be a very helpful tool for the treatment of these high-risk patients. This is an example of a patient previously treated with common femoral artery endarterectomy, and you see the severe calcification in the SFA segment. We have a short occlusion in the tibio-peroneal trunk and a single vessel runoff from the peroneal artery. We have a very calcified disease. It was even difficult to cross the lesion. This is something that you have to take into consideration when you already have a prolonged procedure. You might don't want to waste time also for the excessive vessel prep with atherectomy or other devices. Antegrade, retrograde crossing. As you see, we had to go for reverse cart in order to cross the vessel, and afterwards excessive vessel prep with IVL. It's very important that after this prolonged procedure, we didn't have to spend so much time for the excessive vessel prep. And you see a very nice result after the intravascular lithotripsy on the left-hand side. I combined in this case with a drug-coated balloon in order to avoid restenosis in the long run, and we see an excellent result on the left-hand side with a patent vessel and a very good runoff. We also recanalized and treated the peroneal artery with drug-coated balloon to improve the outflow. Another example, a patient who was already planned for a major amputation after 2 failed grafts, no available vein, and as you see on the right-hand side, you see the wounds from the failed healing of the bypass grafting. The patient was also difficult to cross, once again antegrade retrograde access. After crossing the lesion, Shockwave intravascular lithotripsy for the SFA and the popliteal artery. Afterwards, we achieved already a great luminal gain, dilated the vessel with an impact drug-coated balloon, and then For some restenosis, we placed also two scaffolds in the distal SFA, but it was a very successful procedure, as the alternative would be a scaffold from the groin up to the P3 segment. And in this case, we were able to treat the lesion with a very short stenting length compared to the lesion length. Once again, improved the runoff, and we had a single vessel runoff through the posterior tibial artery, and the patient healed. And we should never forget that this patient was planned for major amputation. Another issue is the treatment of common femoral artery disease. As you see in this case, of course, surgery is a treatment of choice, but in some patients, surgery should be avoided. We have here a patient, a diabetic, obese patient who refused to go for a common femoral endarterectomy. What we did is that we crossed the lesion, and you see here the IVUS run. We have a maximal stenosis, which is subtotal occlusion of the vessel. In this case, I use the IVUS for guidance because it's better. You can better appreciate the posterior wall plaque of the common femoral. Perform an IVL angioplasty with a 7x40, and then with a plain old balloon angioplasty. When you treat the common femoral, you have to keep in mind that the biggest IVL catheter is 7 millimeters, so it might be meaningful to go for an oversized plain old balloon angioplasty catheter. Afterwards, it's very important to change the compliance of the vessel using the Shockwave catheter, and afterwards you can go for an oversized plain old balloon angioplasty, which was followed from drug-coated balloon angioplasty. As you see in the angiographic imaging and in the IVUS run, we have an excellent result with a very good acute luminal gain. We see now a very good lumen, a patent vessel without the use of any adjunctive debulking technology, without the need for a distal protection device. And as you see, we have an excellent runoff without any changes. So to sum up, the Shockwave technology is very simple, and it is not very time consuming. It can be used for a broad application across vessel and disease, and it is a very safe and effective tool across multiple peripheral vessel beds. Thank you very much for your attention.
Dear moderators and colleagues, good afternoon. I would like to thank Shockwave Medical to be invited to this symposium. It's a pleasure to share with you my experience with IVL to safely crack the calcified iliac arteries for EVAR and TEVAR procedures. These are my disclosures. Since 10 years, there are many endosolutions for challenging iliac access, from a paving cracking maneuver to the so-called endoconduits. But with endoconduits, we use curved stent, and we cover the common iliac artery and the external iliac artery, so an epigastric artery is covered, and it could be a risk for extended disease, or aortic stent disease and spinal cord ischemia. We have, of course, the open conduit, an open option, but this is associated with a higher rate of surgical complication and mortality, and of course, higher recovery times. With Shockwave IVL, we have a new horizon calcium management with two portfolios, one for coronary arteries, one for peripherals. The IVL offers solution for all calcified district, from iliacs to the pedal arteries. The IVL addresses complications associated to calcium, such as dissection, perforation, and embolization, preventing the vessel recoil and facilitating the iliac access for large bore devices, that is our topic. PED3 observational study included many iliacs. A subgroup of this study included iliacs for large bore access, and comparing the endoconduits, the stenting rate was very low. Which are the factors to consider? Of course, the length and size of the lesion the presence of the eccentric calcium, but the real lesion at risk is the concentric calcium. And in this case, we have to pay attention to the minimum patent lumen. It's very important the location of this lesion at the origin of the iliacs, at the iliac bifurcation, of course, the grade of this stenosis, and the presence of severe tortuosity. In absence of clear guidelines, our algorithm to use the IVL is, in case of either a minimum patent lumen equal or less than 6 mm in case of concentric stenosis, 1 mm less in case of eccentric stenosis. In case of TEVAR, FEVAR, BEVAR, so larger bore devices, a minimum patent lumen equal or less than 7 mm with concentric stenosis, 1 mm less in case of eccentric. It's very important to accurately check all the lesions because at least one of these concentric lesions could compromise our treatment. And it's important also to find the right balance between a standard profile endograft based on patient anatomy and the low profile endograft to use in case of extremely narrowed access. We have two main indications for IVL-assisted EVAR and TEVAR. To facilitate the endograft delivery, of course, but to avoid the trauma, rupture, dissection, and stenting, but we have cases with aortoiliac occlusive disease and peripheral symptoms. In this case, we have also to improve the iliac circulation and peripheral flow, and in this case, probably we need stenting. Very briefly, I will present you some cases of our experience. This is a female with a continued rupture of the abdominal aortic aneurysm with a very narrowed and calcified bilateral iliofemoral axis. As you can see very clearly from this center line and volume rendering, 3 mm at the level of the external and common femoral arteries. This patient was at risk for open repair with severe comorbidities such as obesity, COPD, CKD, acute kidney injury, active pulmonaritis, and she needed an urgent treatment. But she was also unfit for endo repair with this kind of very challenging anatomies. We treated the patient during the night with a low-profile EVAR percutaneous access with local anesthesia. By using a bilateral and sequential IVL, we increase the lumen gain, we increase the compliance of iliac vessel, and we delivered a low-profile endograft. We can compare the volume rendering and the navigation, and we can clearly see the increase in lumen gain in absence of any signs of dissection. Second case with thoracic penetrating aortic ulcer. On the right side, we use the Shockwave balloon to crack calcium and to facilitating the wall apposition. We need to oversize based on the vessel reference diameter, and we were able to deliver a 20 French sheath in this case for a thoracic treatment with a chimney graft. Third case, another female with a AAA with associated aortoiliac occlusive disease. In this case, 3 mm on both sides and extremely narrowed and calcified iliac arteries. Also, in this case, we can see, watching the IVUS, the lumen gain less than 2 mm. We use the IVL to crack the calcium and to prevent a stent recoil. In this case, we associate an aortic main body, low profile, with a bilateral GOR BBX in place of iliac limbs. We can see the CT scan control with improved flow and with the exclusion of the aneurysm. Last case, a AAA with end-stage renal disease. We can see the multiple concentric lesion on bilateral iliac axis. In this case, it was associated an aortoiliac occlusive disease, and we treated the patient with open repair for the common femoral artery on the right side, and we were able to deliver a standard EVAR without the need of stenting, adjunctive stenting. In conclusion, these are the key points for IVL. This technology is safe, intuitive, and effective. We have a low risk rupture dissection. We don't need endoconduits. We can crack the calcium very safely with a lower use of stents. We can optimize the lumen gain with a low residual stenosis. Thanks to this technology, we have a safe and minimally invasive approach for our aortic procedures. We have the best technical and clinical outcomes with a shorter recovery times. Thank you for your attention.
Well, thanks very much to both Kostas and Stefanos for a couple of fantastic presentations. We do have a few minutes for some discussion. Haven't had any questions in from the audience, so I might start with you, Kostas. You showed some really challenging cases. I wonder if you could just tell me about your experience with both concentric calcium and eccentric calcium, say in the femoropopliteal segment. Do you find that Shockwave works reasonably well for the sort of eccentric or purely concentric calcium?
I think that there was a lot of concern at the beginning about the effectiveness of IVL in eccentric lesions, but we have data from the coronary showing that actually it works also in eccentric lesions. And from my point of view, I don't think that the kind of calcification of eccentric or co-eccentric really influences the performance. So I'm not worried about it. This is not the type of calcification doesn't really influence my strategy, doesn't really change my strategy from IVL to a different modality.
Interesting. So when you're making a decision, say in a femoropopliteal disease, very calcified, between atherectomy versus IVL, are there any features that will help you decide one way or the other, or what's your approach?
First of all, it's the patient. So if I want to avoid the repeat angiograms, if I want to avoid the excessive use of contrast agent, probably I will not go for atherectomy. You have to perform, if you go for directional atherectomy, for example, you have to perform it in many different planes, the control. So I would avoid it. And the second thing is also the runoff. So if I have a patient that has a very bad runoff where I want to avoid any distal embolization, although I always work with distal protection device for atherectomy, probably I would avoid going for atherectomy. And the third parameter is the patient. So if I have a very old patient that is not going to go through a very long procedure, I will avoid atherectomy as well. But in experienced hands, I think that both modalities are complementary rather than comparative.
Yeah, great answers. Thanks. Stefano, you showed some fantastic cases. One of the things we often get asked is how come with a 7mm balloon you can treat iliacs nominal diameters, 12, 10, 12, 14. What's your experience with the pre-dilating with Shockwave and then wanting to post-dilate limbs that might be much, much bigger?
Yeah, right. That's a good question. Yeah, sometimes we use a predilatation, then the IVL, and then the uncompliant balloon. Good news from Shockwave Medical that in the next future, probably during this summer, we'll have the availability for the 8mm balloon. Probably the 8mm balloon will be a new tool for the IVL technology for the common femoral, for example, the common iliac arteries. So we can really increase the lumen gain and in particular increasing the compliance of the iliac vessel. And the compliance, I think, that is the main feature that is really able to facilitate the delivery of our aortic endograft, so of large bore devices.
So you really see that change of compliance allows you to post-dilate limbs much greater than the nominal diameter of a 7mm Shockwave balloon, yeah?
Right.
Yeah, that makes a lot of sense. Well, listen, we're out of time. We've had some fantastic presentations. I'd like to thank both you, Stefano, and you, Kostas, for great presentations and good discussion. And thanks to Shockwave for sponsoring this symposium. Thanks very much.
Thanks a lot.
Thanks, man.